Now it's my honor to invite Bruce Esterline, Senior Vice President for Strategic Initiatives at the Meadows Foundation, who will introduce today's guest speaker. Bruce.
This is my first public announcement that I'm retiring in a month. That wasn't my story today. It's the only reason I mentioned that is because it gives me a chance to thank the Catholic Foundation, Matt Kramer, and Cheryl Mansour and their team for working together for many of those 40 years that I've been with the Meadows Foundation. It's also my opportunity to tell you a little bit about why the Meadows Foundation got involved in mental health and ultimately in the creation of the Institute, which Dr. Keller runs and will be talking about. And it's a personal story from the Meadows family that recognized that it had mental health issues in family and friends, and put mental health as a key initiative on the forefront of its grant making about 15 years ago. And we found over the course of the first sort of few years where we were entering this ecosystem of mental health that there was no go-to place in the state. There was no source of good objective data about how much money is being spent, what's being done with that money, what are the outcomes. There was no strong voice in the legislature for mental health needs. And so we organized a plan to create an organization that could serve in those regards. And the first thing we did was to enlist the support and the help of an organization called Tri-West Consulting, which Dr. Keller was running at the time. And over the next 2 years, Andy and I and his team worked side by side to develop this idea, to vet this idea, working at many community gatherings, lots of conversations with the state officials. And in 2013, the Meadows Foundation made an initial investment of $10 million to stand up the Institute. And we have continued to support it. We put our name on it, so it's the Meadows Mental Health Policy Institute. And it gives me great pleasure to introduce Dr. Keller, who's been my mentor, thought partner, and an amazing friend for the last 10 years. And he can tell you the rest of the story. So thank you very much. Andy Keller.
Well, I think of Bruce as my co-conspirator, actually. He's a great person to design things with, and Bruce, we really couldn't have done this. I mean, it's just been such a great partnership. And I think, you know, we were talking at our table about how I also think we could not have done this, put together what we've done in a community other than Dallas. I mean, Dallas, when I first moved here in 2014 to work with Tom Luce, who was our first CEO at the Institute, I've never been in a more welcoming place than this community, and I've never also been in a community where major philanthropic organizations not only play together well, but work together well and work together in a really coordinated way. And it's just been, I mean, it's truly wonderful. And I'm going to try to note some of that as I go through about how folks in this community have really been critical to some of the things that we've been able to have improve. Because I'm going to say some hard things today, but the hard things I think you already know because you're living them, you're seeing them every day. But I'm hopefully going to share with you some things that give you some causes for optimism, because we are doing better in terms of mental health care in Texas than we were, and we have a lot more that we could do, not just in Texas, but across the country, but we're making some really great strides, and a lot of them are centered here in Dallas and North Texas, so we'll talk about that. I am going to be looking over my shoulder because I got to remember what talk this is, because, you know, different people want me to talk about different things, and so and I get to have slides, so that means I'm very unlikely to stray. We are going to have time for questions. I really am going to work hard. Oh, hang on, I'm going to get my phone because that's my clock, and I got to make sure I stop by 10 after because I could talk about this all day. Because I want to hear your questions and thoughts, because I think dialogue, because you all see this, right? You're involved as advisors, you're involved as part of the staff, you're involved in parishes across North Texas, and so please do think of questions, including questions like if they disagree. I mean, I think it's really important because we don't have all this stuff figured out, so please engage when we get a little bit after 9 to the questions. So I'm going to first say a little bit more about us. So we are about having mental health care be different. So when you have mental health needs, medical needs, we're about making sure that you get better care. And I would say that so many of you may know the Hog Foundation. Well, we're different from the Hog Foundation because the Hog Foundation wants to make mental health better. We don't. We don't care about mental health. We care about mental health care. We want you, when you need help, to be able to get help, just like you do for heart disease, just like you do for cancer, just like you do for diabetes, which is not the case today. It's getting there. And so what we do is we work in communities. 75% of what we do is working with community partners to try to do better things. So probably one of our largest projects, and one of the ones I'll talk about several times today, is with children's health, where we're trying to retrain every pediatrician and family practice doc who works with children in North Texas to have them be able to do a better job delivering mental health care, to have more support in delivering mental health care, and to be able to get ahead of the curve in terms of reaching children who have mental health needs and their families. So that's part of what we do. But then the things that are problematic, for example, the fact that Medicaid wouldn't cover a lot of the health care costs in those pediatric settings, we go to Austin and we change. And then when we know we needed to have startup costs for that, we went to DC and changed that. So we've passed quite a few laws, and this national thing has really come about because of COVID. During COVID, the role of the federal government really increased, but also the federal government's funding for mental health really increased. And so it became a much more important thing for us to look at, and we'll talk some about the federal piece as well. I just want to say that, since our founding on the policy side, because I'm not going to talk too much about the policy side, I will a little bit, but we've been involved in a lot. So the state of Texas's funding for mental health is up over 33% since when we started. And while we're not responsible for all of that, we're responsible for a fair bit of that, galvanizing information, because before we got involved, we didn't even know how much we were spending. By the way, when people say Texas is 50th in spending, it's because we didn't used to count all of our money. We're probably like 34th now, which, I'm not particularly proud of that. I mean, my dad didn't say, go be 34th, Andy. We want to be first. But I think what's most important is that we have it now strategically aligned. The money that we're spending at a state level, and we're not only about government spending, but government spending is not irrelevant. It now has a strategic plan that we helped design back in 2015. And so we've been working at this for about 10 years, and have had about 86 legislative priorities through the last session. We've gotten 78 of them enacted, so we've been very successful in Austin. Part of that's because we do good work, but a lot of that's because there's a bipartisan consensus in this state that we need to do better. And we're very fortunate to live in a state where people are able to work together to move these things forward. This is prior to this session. We have about 40 more initiatives that are up, and we'll know how they all sorted out in about 12 days. I think 12 days is when Synod Day is. So that's exciting. And then we are doing stuff in Congress too. One of the most important things we worked on last year was the Bipartisan Safer Communities Act, working with Senator Cornyn, who worked with Senator Murphy from Connecticut. This is often called the gun bill, but it was actually more of a mental health bill. There's about $11 billion of mental health funding in that. So we work very actively on that, not because we're trying to get more money, but because we actually want it to go to things that work, and things that can be helpful, and things that get to children and other people who have higher needs. So that's a little bit about us, and I'll refer to some of that as we go through. But I want to start out with this question. What if we decided to treat mental health the same way that we treat heart disease and cancer? Because we don't. We don't. And the one big thing that's different about that is up at the top here. In Texas, we lost almost 16,000 people in 2021 to suicide and to drug overdoses. And why am I giving you 2021 data when it's 2023? Well, because the 2022 data for both of those causes of death haven't been finalized yet. I mean, I could tell you, well, actually, it's a little harder now, but we probably could tell you how many people died from COVID a month ago. We have pretty recent good numbers on that. And, and during the pandemic, we knew it like on a daily basis. We didn't know exactly, but we had a pretty good idea. With these illnesses, we don't care about them as much, so we don't track them as much. And they're also the only illnesses of the major causes of death where we have seen year-over-year reductions in progress, year-over-year worsening of the death toll, year-over-year worsening of the number of young lives that are cut short through suicide, but also young lives that are truncated, not necessarily through suicide, but by not being able to finish school or achieve or be able to have a family connection that they need. So this is a real problem, and a lot of it comes from this simple diagram, which is important to understand. So when we talk about other healthcare, we try to find out if you're sick before you know it, right? So with my heart disease, they looked at my cholesterol because they wanted to see, Andy, in your 30s, are you likely to have a heart attack in your 50s or your 60s? And they knew it was quite possible because my uncle did, and my grandpa did, and my dad had heart disease, and my brother has heart disease, so they knew it was pretty likely. And when they found my cholesterol, they've been working on me since I was probably 35 years old to improve my diet, to take medication, to do all of that. It's the opposite of what we do with mental illness right now. With mental illness, we wait till you know you're sick or until people around you think you're sick, and that's usually because things are pretty bad. And so the idea of a crisis is when most people start to think about mental health. When your son has not gotten out of bed, when your husband is suicidal, when you're starting to see things that aren't there and people are kind of freaking out because they're like, why is that going on? Even people who have psychosis, which is one of the most severe mental illnesses, do not get care until 2 to 3 years after their symptoms emerge. Why is that? First of all, it's hard sometimes for people to understand what's going on, but also a lot of times it's a young person, you don't want to think of your son or your daughter as having a psychosis. So you come up with all sorts of reasons why it's okay that they're up in their room and they have these funny ideas about, being followed by people and all these different things. It's really hard as a layperson to notice any illness. I mean, think about it. If you had a lump on your hand, would you know what that was? I mean, would you know why? Was that a cancerous lump? Was it like a benign lump? No, you would go talk to your doctor. And I think that's the idea here. And I'm not talking about sadness. I'm not talking about anxiety. I'm not talking about anger. Those are normal human emotions. And we're going to talk about that some when we dig into this. But when people become unable to do things in their daily life. So I have an anxiety disorder. As I was a little kid, there were lots of things I didn't do because I was too worried. I didn't go outside as much. If I was going to walk across this room, I would have really had a hard time because it's hard to find the same color part of the carpet to step on. I would have had to take some very large steps. I mean, even though I didn't talk about that so much, it made it harder for me to get around and do stuff. That's an illness. That is a level of thinking and anxiety that gets in the way of your functioning. Being worried before you give a talk, that's normal. So that differentiation is very hard for lay people, for anybody to make sense of, just like it is with any other illness. So that's why we have the problem we do. And this, by the way, is the way our system's designed. Our system is designed to put you in a hospital, send police, do other stuff when you're in crisis. The hopeful part of this is also what we used to do with heart disease. So my grandfather was diagnosed with his heart disease upon being resuscitated from his heart attack. So he was dead for 6 minutes. They brought him back. He was in a coma for 2 weeks. And then when he woke up and got better, they sent him home on a low cholesterol diet. That's when his heart disease. And that's where we are today with mental illness. We're sending you home on your low cholesterol diet after your suicide attempt. We're not starting 10 years prior. That's the average amount of time that symptoms begin before we give people help. So let's look about how this works with depression, because it's actually not as difficult to do something about as you might think. So we've got about 21 million people in America. This is pre-COVID. There's more people now with depression than there was before COVID. I'll talk about that in a sec. But 21 million people every year are going to suffer from depression. We only clinically recognize 47% of them. Why? Because we don't try. We don't ask. We don't have universal screening for depression in primary care like we do for heart disease, cancer, other types of things. But here's an even worse thing. That half that we do clinically recognize, we only get half of them to treatment. Why is that? Because we send them home with a list of therapists to call. Well, first of all, a lot of those therapists are no longer in the network, or they're not accepting patients. Also, if you're depressed or anxious and you've got to go get your own care, how's that going to work out? How are you going to, if you're too anxious to go to work, how are you going to call up people, especially when the first 3 tell you that they're not going to see you? Or let's say you're a person in poverty or a person who lives in a part of town where there isn't a clinic close to you, and this is before telehealth. How are you going to get transportation to that? So this is a huge thing. And then this is actually the worst part. For the 24% that do get treatment, only 9% get evidence-based care. We're still giving kids play therapy when they're depressed. Play therapy can be good for development, but it does nothing for depression. Depression is actually an illness. And when you're working with children who are depressed, you're going to need to work with the parents. You're going to need to do family therapy. There's evidence-based things that happen, but we don't do them. So of the 2 million lucky enough to get the care that works, 2/3 get better. Our response to treatment for people who actually get the care that works is 2/3, but yet it's only 6% of the total because we do a terrible job with how our systems are organized. Now, for me, that's a hopeful thing for me. And the reason I find that hopeful is those are very fixable things. We know how to screen for depression and for anxiety disorders. We know how to effectively refer people. When my mom had her breast cancer or findings from her self-exam, I mean, they got her into an oncologist super fast. Why? Because they care. Because they thought it would be a big deal if they didn't, because it would be a big deal if they didn't. We don't do that with depression now, though we're starting to. So the other thing that's really important to keep in mind and what makes this hard is that 75% of mental illnesses begin when you're a child. And that's different than cancer. We have some pediatric cancer cases, but most come with people like me, who you expect to be sick, because I'm old. Same thing with heart disease, which we don't expect children to be sick. And 75% of these cases begin in childhood. So let's just look at the progression of little Andy. So that's little Andy, right after my baptism. It was in a Methodist church. So later I got baptized in a, well, I didn't get rebaptized, but they recognized it in the Episcopal Church, which is somewhat recognized by y'all. But anyway, I think I'm going to go to heaven. And my mother's pretty sure I'm going to go to heaven. But this is near the time when they wrote in my baby book, my mom was super impressed because I said the word, "I'm so anxious." And I think she thought it was cool that I knew the word anxious at age 4. Didn't really think so much about why would he be saying that. And she also called me the woof kid, because I was always like, "Mom, what if there's a tornado?" Now, we lived in Washington State. There are not tornadoes in Washington State. There are volcanoes, and we did have one go off when I was 16, which was interesting. But, what if Dad doesn't come home? What if, the school burns down? I mean, what if the house burns down? When we would watch a TV show, whatever went bad there, what if that happens at home? That sort of anxiety was a just daily part of my life, and I didn't know it was an illness. I actually got attacked by a dog when I was little too, our dog, and I actually had some PTSD symptoms around that would kind of weird me out a little bit. But then I think, well, I guess that's just what happens with your brain sometimes. Part of the reason I did okay with that was my mom was super supportive. My mom did a lot of reading about how do you parent a kid who's a little harder to parent, and she had support from her family. I had grandparents around, I had other family supports, so I got through that okay. Didn't get actually any treatment, so this is me going to prom when I'm 18. That's how people dressed back then. It was good. I had a great date. I was fine. I went on fewer dates in high school than I would have if I could actually feel comfortable talking to people who I didn't already have a reason to talk to. But I was pretty happy. But the reason I want to show you this is the age where if I'd had a more severe mental illness, it would have likely manifest. This is the age between 15 and 25 when psychoses, bipolar disorder, other more severe illnesses than anxiety tend to manifest. And interestingly, most people who do develop those illnesses had other anxiety symptoms like I did before. Doesn't mean if you have anxiety you're going to develop a psychosis, but it does mean if you have a psychosis, there's some things in your brain that throughout your development are going to manifest differently than someone who doesn't. So if we had good screening and detection for my anxiety, not only could I have gotten some supports and my family gotten some supports earlier, I would have been on someone's radar if I had developed a psychosis then. And that's really important because getting in care sooner, within a year of developing a psychosis, you have much better outcomes. And then this is me at age 49, a little bit younger than I am now. But the reason I like to show this is this one I would have died on average if I had had a severe mental illness in Texas. Because that's when people with the most severe mental illnesses die on average at age 49. Not from suicide, but not from things directly related to the illness, but from basically not taking very good care of yourself, from some of the side effects of some of the older school medications people used to be on, but mostly just from living in poverty and having an unhealthy lifestyle where you die from heart disease and other metabolic related diseases. So this is something that we need to disrupt, and it's just like any other illness. So I really wanted to spend a little time helping you understand that because this is fundamental to everything we're trying to do. If you don't understand anything else for today, the idea that we need to get to children and families early, and we have done this before with other illnesses is something I hope you have some hope from, because it's not rocket science, it's just basic healthcare. One of the things I'll tell people sometimes, and this slide shows it, is our goal is to make healthcare as bad for mental illness as it is for everything else. Because healthcare is not very well organized in the United States. We have a lot of problems. We have uninsured people. We have a lot of other stuff. But year over year, for the last 20 years, we have reduced the number of people dying from heart disease and reduced the number of people dying from cancer, which is the opposite of what we're doing with our diseases. So that's all. That's all I want. Is I just want it to be as bad as everything else, as opposed to dramatically worse than everything else. And then we can make everything better after that. So that's what we want to do. And most of what needs to happen is in primary care, because 2/3 of mental illnesses aren't that bad. My anxiety was something that would have been readily treated if it had been reached when I was a kid. It was actually pretty readily treated in my mid-20s. When I got my first organized care, I was able to actually talk to people without, feeling like something horrible would happen. And it's gotten better throughout my life as other treatments have become available. Fish oil is actually quite amazing. If you have anxiety, talk to me sometime about fish oil. It's a very useful thing to take. So anyway, this is the background for what we're doing. So then, what is the state of mental health and well-being given these structural issues in America today? Well, it's not good. And so I'm just going to show you some things. We are still sending police too often as the front line, and of those encounters, some police are actually quite sophisticated about how they respond. Dallas PD, very sophisticated. And we're going to talk a lot about the things they've done at Dallas PD. But 1 in 4 people who die from police shootings are people with mental illness, because things go or have a harder time and sometimes go wrong when they have to deal with mental illness. I'm going to start drinking the water now so I don't start coughing. The jails are still the most likely place where people get their first care, and we have lots of people. I've already talked about the suicide deaths. Those are national numbers. The ones I showed you earlier were Texas numbers. And so many folks are in our ERs that we're actually having a hard time serving other people because they're backed up with people with mental illnesses. So it's not great. The other thing that is happening is we're seeing that anxiety disorders and depression are actually affecting more and more people post-pandemic. Numbers are up over 3 times what they were before the pandemic for subclinical levels of anxiety and depression, which are correlated with higher levels of. And I'm not going to, I wanted to show you these numbers to prove that there's numbers. I didn't expect you to read any of these. I just wanted you to say, oh, he's got numbers. But when you look at the age breakdowns, those numbers are very different for people my age and people who are older. People my age the numbers are around the 20%, well, they're around the average in my age, much lower for people older than me, but for 18 to 29-year-olds, 40% of people as of March were struggling with levels of anxiety that got in the way of their everyday life, and similar proportions in terms of baseline numbers for depression. So if we wonder why are people not going back to work, why is the economy what it is, this is actually one of the biggest drivers of that, this sort of post-pandemic thing. So there's a couple things from the pandemic. One that not a lot of people know is the only thing that was more correlated with mortality, death from COVID, was mental illness. The only thing that was more correlated than mental illness was age. Age, of course, was the biggest correlate. But mental illnesses, depression and psychosis in particular, if you had those, you were much more likely to die from COVID than if you had asthma or cancer or any of the other comorbid things, diabetes, that everybody was warning you about. We actually had to go to the CDC and petition them to add depression and psychosis to the list of people who got early access to COVID COVID cures, because they just wasn't on their radar. And a big reason it's not on their radar is we don't systematically ask people. When those first 11 hospitals in New York released their data about who was most likely to die from COVID, they gave all the tracking and screening data which they had for diabetes, heart disease, everything else. They had none for depression or psychosis. They didn't know who had depression or psychosis. It wasn't until we did retrospective studies later that we found out it had such a huge effect. This lack of attention from the healthcare system is a big reason why we have such bad outcomes today. But the biggest impact is on our youth. And I think many of you may have seen in December 2021, the Surgeon General put forward the first public health advisory related to mental health that talked about the epidemic of mental illness going on among our youth today. And it's not just that we're doing a better job asking. Youth and young people today have higher rates of anxiety and depression than they did when I was a kid. And there's a lot of reasons for that. One of the biggest correlates, because this started in about 2012, is social media. And so people like to say, okay, well, social media caused it all. Social media caused some of it, for sure. The American Psychological Association put out a fantastic overview of that last week that looks at some of the causes. But it didn't cause most of it. I think it's much more complex than just social media. And a lot of it is I think the fact that when I was a little kid, remember I mentioned my mom had my grandparents, my aunts and my uncles, all those people. Who has that? Who has that now? My kids didn't grow up with that. My kids grew up with me and my wife. We were able to create some supports around them with friends, but we had a lot less social support. If we didn't have the resources we did, you can imagine how hard that would have been to bring up kids. That's what's happening today. And the fact that we're using these devices a lot of times to do child care as opposed to another human we just have so fewer human contacts for our children today. There's a lot of factors. And I think parents and families are the key to this, as are faith communities. So when we think about these factors that are driving the higher rates of illness, I don't just mean higher rates of worry, higher rates of sadness, higher rates of disillusionment. I mean illness that leads to suicide attempts, that leads to actual successful suicides, that leads to lives gone awry, lack of engagement in jobs, all sorts of things. It's something that faith communities can really have a big impact on, and I hope we get a chance to talk about that. This is a very disturbing set of trends that we looked at after Uvalde, because the legislature obviously was quite concerned about the horrible impact of that mass shooting. We just had another horrible example up in Allen. If we look, though, at children and youth, the number of them dying from mass shooting fatalities actually isn't that big. That doesn't mean we're okay with it. It's horrible, it affects communities. The bigger causes of mortality among our children in Texas are actually from regular old homicide. Homicide is the biggest cause of death among Texas children of any particular cause after accidents. And the third one is suicide. So these types of violence towards self or others are really at an epidemic level. We lost a young man, I'm sure some of you may have seen it in the media. I'm on the board of ESD. We lost one of our students last month to suicide, and I talked to our head of school about that, who obviously was heartbroken, and we were worried about, would this happen with other students? And I told Dave, I said, Dave, if you're going to care for children today, you're going to lose children to suicide, because it's an epidemic that you cannot control just from your school, just from your family, just from your diocese. It's something that we have to come together and really look at both what are the root causes, but also what can we do when children and families struggle with this. So that is important. And I want to talk a little bit about this whole debate that we have between mental illness and guns. So this is the big sort of canard that you could have to do one or the other. The reality is guns do have an effect, but I'm not a gun policy expert. I'm a mental health expert. Mental illnesses are not the same as violence. Mental illnesses do not cause violence. Most people with mental illnesses are just like anyone else in terms of the level of violence they're going to have. Hate, violence, unfortunately, and I think we in faith communities know this better than anybody, is being human. I mean, all you gotta do is read the Bible to understand that this is something that we struggle with as a species. It's not something that was invented in the era whenever, somebody decided mental illnesses were a thing. And so we can have humans carry out violence for good reasons, self-sacrifice. We can have people carry out violence for really bad reasons. And certainly a hateful ideology, like apparently this person in Allen got caught up in, can exacerbate that kind of thing. But the thing that we try to point out is that, and I want to jump ahead, is when we look at schools, there's actually really good research that came out in 2021 from the US Secret Service that actually shows that mental illness is a major driver of these school shootings. And the illness, some of it's psychosis, but the vast majority of these school shootings are coming from kids who are depressed and suicidal, but they're also angry at a particular group that they feel is responsible for their state. And so they're going to go take out that group and go out and sort of homicide, suicide, death by, kind of going and having this final confrontation. We did some analysis of this after Uvalde. We actually did this analysis after Santa Fe in 2018. We refined it after Uvalde. And there's about 10,000 kids at any one time in the state of Texas who meet the profile of the Uvalde shooter. And I'm here to tell you, had the Uvalde shooter been recognized in his school when he came in with cuts on his face in 2020 in the fall and had received regular old mental health care, Uvalde wouldn't have happened. And the reason I know that is because we treat kids like that all the time. We treat kids like that shooter every day. Now, the 3 weeks before he did it, when he's buying those guns, I don't know what would have happened then, because he was in a different state then. But if we got to him in the fall of 2020, it would have been a different outcome. Most of these kids who fit this profile are never going to do anything like that. The number of things that have to happen for you to end up in a situation where you're going to a school shooting is like almost infinitesimal risk. But all of them are going to have bad outcomes because look at his family. Look at his grandparents struggling without supports to try to control him and to be there. The police visited him 8 times, did nothing. The school knew that he was having problems, but they didn't really know what they were. They knew he was just an odd, strange kid. Odd, strange kids are kids who are not doing well, and they need help. They need help from their community. So that's what we've really tried to focus on. I'm going to skip past this because I want to get down to talk about these reasons to be helpful, because we are doing some things in Texas now which I think are put in place the structural elements to be able to turn the tide on some of this, both the lower level mental health needs, but also some of these more severe mental health needs that are driving violence and death in all of our communities, not just in our impoverished communities. Mental illness is a pretty equal opportunity set of illnesses. Now, if you get the illness in an under-resourced neighborhood, a marginalized community, a community where you don't have trust in the healthcare system, of course you're going to have worse outcomes. But it's not because you get mental illness more, it's because we give you even less care than we give everybody else. But there are some reasons to be hopeful, and one of them, it happened right here in Dallas. Anybody ever heard of the Right Care Team? A couple of you? Yeah, awesome, a couple of people, excellent. The Right Care Team is something that we started back in 2016 with a grant from the Caruth Foundation, the Communities Foundation of Texas, which is a wonderful organization. You know, being able to do big, bold investments to try to do something different. They invested $8 million in a partnership between Dallas Fire and Rescue, Dallas PD, and Parkland to say, rather than send police and then bring people to Parkland when they have a psychiatric emergency, let's send the social workers from Parkland along with a paramedic with police backup, because sometimes there are violence in other types of situations, but really with the paramedic and the social worker in the lead, and they went out and did that, and this has been extremely helpful. We have only seen arrests of about 4% of the people that are seen in this program. Half of those people were people who had outstanding warrants. If you have an outstanding warrant, that means we're looking for you. So those people needed to be arrested. Now, I'm not saying it was just, I'm just saying the policies are in place for them to be arrested. 96% of those folks were able to get clinical care and were able to be back in the community with proper clinical care in place, which I would say MetroCare was one of the most important organizations for that, because we're so fortunate to have a mental health provider here in Dallas that will do same-day appointments. That is same-day medical appointments. So it wasn't just these three organizations, it was the whole community. But this model is now going across Texas. DART has implemented a version of it, and some of the 13 police agencies that work with DART are starting to adopt these measures. Irving has adopted it. We have just a new program down in Galveston. San Antonio is using the program. We also have communities across the country being able to take this program up, a program that started right here in Dallas. And a lot of that got accelerated after George Floyd's murder, and people began to step back and look at what are we doing with policing today. It was no accident that former chief, then superintendent, and now just CEO David Brown, who used to be our police chief here in Dallas, went to Chicago and scaled this program there, but we also have New York, Baltimore, other cities looking at this. This is a really important thing to do, not because, it doesn't really get to the root cause of the problem of getting there earlier, but it gives us a better response when there's crises, because these are illnesses, and the fact that we have our whole justice and correctional system set up to respond is something we have to dismantle, and we have to create something different, and we've done that here in Dallas. And so it's a wonderful program, and we're very fortunate to have an organization like Parkland here to be able to take the lead on the clinical part of that. So that's one reason to be hopeful. We're changing the way that we respond to crises. We're also transforming the treatment of depression. This is something called collaborative care. And the primary care provider right there right now is currently in every primary care practice across the United States serving about half the people that get help for mental health treatment. Half of people get their medication, get whatever help they're going to get through their primary care doc. Most of them are not getting very good care. When I showed you that half the people get missed and half the people never get care, and then 2/3 of the remaining people get bad care, it's because they're getting care from primary care doctors who give them too much medication, the wrong medication, or don't notice their symptoms. Not because they're bad, they're wonderful, but they got 15 minutes to figure out what's going on. So with collaborative care, what we do, and this is something that now your commercial insurance pays for, Medicare pays for, and even Texas Medicaid pays for, because of us. But if Texas Medicaid pays for something, it's kind of mainline, right? Because we don't really do that here. We'll pay for a psychiatric consultant and a mental health care manager in the practice. I mean, would you get your blood pressure taken and your temperature taken at every medical visit if there wasn't a nurse? I mean, do you really think the doctor would do that every time? They would not, because they're very busy. They have a nurse there to make sure that stuff happens. Same thing with this behavioral care manager. They're there to do the screening for depression, anxiety, but they're also there to help you get the care you need, and to also bring in a psychiatrist if there's going to be medication. And what we find is when you have a psychiatric consult, we give you less medication, and we give you better medication because we actually know what to give you. And the other thing is medication only works about 40% of the time when you need medication in terms of the first trial. By the time you get to a third medication, it works 2/3 of the time. So having you stick with it and work through that is a big thing the care manager does, because it's hard to get care. But that's also true for other things. How hard is it to get cancer care? I mean, colonoscopy, not fun. So like we have to do all sorts of things in medical care that don't work out very well. But by being able to have the right staff in place, we see treatment response rates go up to over 60%. And so it's pretty cool. So we're doing that across Dallas, Fort Worth, but also across the whole rest of the state because we got Lyda Hill's Lone Star Prize, which was a $10 million competitive award that we got in partnership with UT Southwestern, where we're taking this model across Texas. And so we have 8 health systems in North Texas that are implementing it. We have health systems across the rest of the state that are doing it. And our goal is to have 10 million Texans in just 3 more years. We're up to about 4 million now, who are getting their care in health systems that provide mental health care in primary care. And I want to talk just a moment about children's health here. Children's health, some of you may have heard of their big initiative, which is the behavioral health integration and guidance project, which is one of the worst names anyone's ever come up with. But big's kind of cool. It makes people feel like it's important. But it's an amazing program. They've raised about $40 million to implement a flagship primary care practice down in the Redbird development. And then we've been training primary care docs across North Texas. We have so far in the first year trained primary care docs serving 150,000 children in how to do a better job, which mostly means doing a less bad job. It means not ignoring it, not over-medicating, making sure you involve parents and caregivers because they're critical to children getting better. You can't do this without the parents and the caregivers. So I think by the time we get to 2025, and Bruce, we've known each other then 15 years, we're going to have very different outcomes here in North Texas because we're going to be getting care and better care at the point when these symptoms emerge, and we're going to have families part of that care delivery as opposed to just giving someone a medication. So I'm pretty excited about that. And then this is the last thing that I'm pretty excited about, which is scaling telehealth across Texas to meet urgent needs in schools. So schools are a place where we see a lot of mental health needs emerge. Why? It's because that's who spends most of the time with the kids. So the biggest sample we have of a child's behavior is what happens in schools, and teachers are often on the front line of that. We do not want teachers to be therapists. Education is a really important job, but when a teacher notices a young person like the young man at Uvalde, or maybe someone more like me who just didn't want to go outside at recess and we're wondering why that is, we want them to be able to have someone help that child. And so the point of this is not to get teachers to dabble in mental health. It's also not to help them without the parents. You cannot help kids without getting their parents involved. So the Texas Child Mental Health Care Consortium has a program called TChat, the Texas Child Health Access Through Telehealth Program. Let's just call it TChat because that's a lot easier to remember. What this does is it provides access in a school where there's a memorandum of understanding between one of our medical schools and the school that if a child has an urgent mental health need, they will get same day assessment by a child specialist, same day assessment by a child psychiatrist if they're very concerned about the child, with the parents' permission. If it takes a few extra days to get the parents' permission, that's fine. They'll wait because they need to do that. And I asked one of our lead psychiatrists about this after the Uvalde shooting. I said, hey, I'm going to get asked by committee leads, they called us the afternoon after Uvalde, the state leaders called us to say, what should we do? And we said, you should do what we told you to do last year, which is to do this program and to do some other programs I'm going to tell you about. But I asked one of the lead psychiatrists, see out there in West Texas how many orange dots, orange places there are. West Texas is a real leader on this particular program. Part of that is the only way you're going to get health care in West Texas is telehealth, because it's a long way to drive between places out there. And so the folks at Texas Tech Lubbock, I asked the lead psychiatrist there, Sarah Wakefield, I said, would it be accurate for me to tell members of the legislature that we have stopped a few kids like the Uvalde shooter through this program? And she goes, no, it would not be accurate to say that. And I said, well, what do you mean? I thought that was the whole point of the program. She said, it would be accurate to say we've stopped a lot of kids, because that 10,000 kids, the 10,000 kids who meet that profile are very easy to see in school. They're not doing well. They're in danger of dropping out. They're getting in fights. They're coming in with cuts on their arms, on their faces. And so being able to get those kids help is what this program is about. This program has been scaled so far to reach 3 million of our 5.3 million students in the state of Texas. And by the end of next school year, we're going to have it in every school. And that's something that we're really excited about. It's also something that we need to be in dialogue with private schools about, because private schools are just as important in being able to access this network, and that's something that we would love to talk to y'all about how this source of resource could be available outside of just the public schools, because it's not just limited to that. So, however, that's not enough. Having a telehealth visit is not enough to help some kid like the Uvalde shooter get better, or some kid like a child who's at risk of suicide, or a child who's at risk of homicide, or a child who's just at risk of a really bad outcome like getting expelled from school and not graduating, get better. So what are some of the things that actually are being heavily invested in? The state budget was agreed to by both chambers earlier this week, and there are historic investments in being able to build the infrastructure we need for more severely impaired children. So part of that is taking the TChat program statewide. Every school is not going to want that. Where we think we'll probably get to about 98% of students through the program, because 2% of students are in schools where they have other options or other types of things that they believe are going to work better. That's fine. We don't want to impose anything, but we've got about 5.2 million students, 1,181 school districts currently in the pipeline to get signed up for this program. So that will help us find the youth. This is a really cool treatment called multisystemic therapy that in 75% of cases will eliminate the risk of violence. 75% of cases in a 20-year follow-up of kids who are at the highest risk of violence will not be violent. And so MST is something that we're scaling up now across the state. And then we have a few kids that we're going to need to have psychosis treatment for, because if you have a psychosis, you're at pretty high risk of bad things happening. And actually there's a 15 times higher risk of murdering somebody if you have an untreated psychosis than if you don't. The good news there is it goes away if you treat the person. Even if the psychosis isn't fully controlled by the treatment, being in treatment helps get a person on a more normative course and helps make sure that people are safe. So that's the thing we're doing, and these are the number of teams. We need in Dallas about 37 of these teams. In all of DFW, we need 12 in Dallas. The state's funding 23 new teams. Actually, I think it's going to be more like 27 because they added some through the child welfare system. We'll probably get 6 of those teams here in DFW, 2 in Dallas. So, you know, it's not going to meet all of the need, but part of why we can't just turn an on switch here is workforce. We don't have the workforce to, even if we had all the money in the world, to implement all these programs we need. But this sort of systematic investment is something that we're really excited the legislature's doing, and it's something that's going to help people here in Dallas. And we're going to be hopefully working with some foundations to target these services to some of our higher need school districts in terms of the ones struggling the most with violence and suicide. So that's what I wanted to share with you today. It's a set of mixed things. Some of it's kind of sad, but you kind of already knew the sad part, right? You already knew that things were hard. I think the thing that we need to have more attention about is we actually have some things we could do. So I would love to have any questions or discussion or anything from y'all, including about this whole point about what's a mental illness, what's not a mental illness, what's the role of faith communities versus medical providers, because these are thorny questions, and it's the kind of thing we really need to sort through if we're going to actually do a better job getting people help. So give me a question. One here.
I have a question. You mentioned it here towards the end.
Yeah.
A shortage of counselors and going to a counselor and finding out that they're not taking new patients. But most of all, just the education requirements for counselors seems to be, there are barriers of entry for people of all different backgrounds economically. It seems to take a very long time, and honestly, you have to be independently wealthy to go through the process. So are you working at all with universities to try to change that?
Yeah, great question, very insightful question. So let me start specifically with the thing you brought up about credentialing of therapists. We think that it is, stupid, the degree of things we make people go through. There's just no reason for a lot of it. And also, it's very racially and culturally biased. A much higher proportion of Latino, Black social workers do not pass the test the first time through. And actually, the NASW has recognized this. So there's actually, I think, pretty wide recognition in the industry right now we need to change this. It's something actually the regulators need to change, the state needs to change, and so we're looking at that. The biggest barrier, though, is this interstate licensure piece. I mean, if any of you have kids in college, this is a nightmare if your kids are in any sort of treatment. You technically need to be in the same state as your provider because of their license in order to get telehealth. One thing you can do, by the way, on that is you can lie. They don't know. They don't know where you're at. So I would highly recommend that if you're out of state and your provider asks you if you're in Texas, you just say yes. Because it's stupid. Really? I mean, it's just one of the dumbest rules I've ever had. So I would strongly recommend that. So there's some laws like that, but here's the other thing that's bigger. There's two things I think that are bigger than that. One is that we have misdeployed our workforce. When heart disease risks came up, we didn't go train a bunch of new cardiologists and send the cardiologists out to find us. We said, no, let's leverage primary care. A psychiatrist who's in the kind of program that we're doing here in North Texas can serve 3 times as many people as part of that primary care practice as they can if they're just in solo practice. So this idea that you go straight to the psychologist or the psychiatrist or the social worker without involving your primary care doc, we don't do that for any other type of medicine. So we need to redeploy. That's an important thing. And then the second thing is we need to crack down on insurance companies. There's a bigger shortage today of primary care practitioners than there are of psychiatrists. And while it's hard to get a primary care practitioner, I mean, I'm on a wait list at UT Southwestern. I had to pull strings to get into one. You can see one. You can get to one. Why? Because the insurance companies will pay what they need to make sure there's primary care, and they are not doing that for mental health. And so we have an initiative that's part of this Lone Star Prize where we're working with business leaders to point out that businesses right now, and the DFW Business Group on Health is a huge ally of ours, are getting gypped. Like nobody's actually getting their money's worth with the insurance, and it's not really Blue Cross's fault or Anthem's fault or United's fault. It's the fault of the industry that has not come to terms with the fact that they're going to need to pay probably 50% more. And that means your premiums are going to go up. But, people are willing to pay that. We just have to get it moving forward. So I think it's going to take congressional enforcement to probably make that happen. So those are, I think, the things. And we're working on all those things. I think, sir, you had it.
Yeah, my view of the world is from my time at Parkland, and I just want to thank you for saying that. I also want to really compliment you because, again, through that view from the Parkland side, the first thing was the person on the street who's in trouble. You're taking care of that. So a comment and then a question. The second is 110 ED rooms at Parkland, half are mental health. I hope it's less now. I don't know. So, I mean, that's where, although the police would just sort of bring them there, but that's changing slowly. The third thing is moving into primary care. That's a huge issue about normalizing that because that's not the way we were trained at all. Absolutely. So I think that's a major thing. The fourth thing, the last thing that was going on when I was leaving Parkland was that Fuad Khan was dealing, I hope, with you.
I love Fuad, yeah.
Okay, all right, because the idea was, not just look for the kid that stands out, but screen all of the kids in DISD. Is that still going forward?
Yeah, so it's a little tricky in terms of screening through school because schools are not set up to be healthcare systems. And parents are extremely concerned right now about mixing non-educational things. And I understand that. I mean, I think some of it's overblown, but I understand as a parent being worried about that. What we want is universal screening in school clinics, in school-affiliated clinics. We really want it at the doctor because these are private things. And I mean, as someone who has a child who's had a mental illness, I really didn't want some of his teachers knowing that, right? Because like they would have treated him different. I had one teacher in particular who was pretty sure he was having issues, and she's like, well, why does he keep going to the doctor? I'm like, it's literally none of your business. And she's like, well, I just feel like there's something. I go, there is, but I'm not going to tell you because I want you I need to know how to teach him. I think you know how to teach him. Teach him. Do the things you would do as a teacher. You do not need to be his therapist. And so I think it's really tricky to get into schools. And Fuad, I think, his whole point, the big thing that he helped, this is Dr. Khan, Fuad Khan, formerly, who has been back and forth at Parkland. He's actually back now up in New Hampshire, but he's still consulting with Parkland. But there's great people there on Parkland's team. Is really trying to get the Parkland clinics and the school-based clinics and the DISD clinics to do that. And it's exactly right on because we can't wait till people figure out they're sick. We got to figure out they're sick before they do and before the people around them do. Otherwise, we're never going to get ahead of this. And I do want to comment on your point about primary care. Absolutely, it's a change in mindset because people don't want to do mental health care, but the reality is they are doing it right now. It's coming up at the end of the session. They're going, oh, by the way, I'm suicidal. Oh, gosh. And then, okay, now it's going to blow up the rest of my day. I'm going to write you a pretty heavy-duty prescription for the only antidepressant I really am familiar with, which may not be one that's even the best one anymore. So what we're doing is we're trying to put more resources into primary care, embedding the psychiatrist and the care manager so they have a team. That way the doctor actually has time to do the doctor part, but they have other people who can kind of take care of the other part. And that's the only way it's going to change. You have to put a workforce there. You can't just expect primary care docs to do more than they already are. So those are, I think, the main ways. Does that make sense?
Fantastic work.
Thank you.
Thank you.
Well, only in a community like this can this be done. If you didn't have people like Children's Hospital, the Crystal Charity Ball, several individuals who gave large amounts to Children's, the Caruth Foundation, obviously the Meadows Foundation, Lida Hills Lone Star Prize. If we didn't have all that stuff here in North Texas, we couldn't be doing these sorts of large-scale transformations. We're so fortunate to be. You should be so proud of your community. All right, those were friendly questions. I want some hard questions. Yes, ma'am.
What about for people who refuse treatment?
Yeah. So the reality is that can happen in multiple ways. First of all, let me just say, I love people who refuse treatment. I only started taking a statin last month after 20 years of refusing to do that, and I am perfectly glad about that. Like, I got healthier, I did a lot of other things, and now I'm at an age where, some of those things I was able to do to stay healthier are harder to do. So I'm all over that. And I think treatment, this is why I said that I want mental health care to be as bad as the rest of other health care. We push too many medications, we push procedures, we do all sorts of things in our sick care system in America. So you have to empower people to not just go with the first thing that they're recommended. I encourage people, I tell all of my friends when they say, hey, things aren't working out well with my therapist, I said, well, have you had a comprehensive diagnosis, a comprehensive evaluation by somebody who you trust? And almost no one has. Almost everybody gets started on treatment therapy by just having an initial visit. They're put on medication. And sometimes that's fine. I'm not anti-medication, but I am anti-misuse of medication and overuse of medication. So if you have concerns about your therapy, good. And go find somebody who's going to do the kind of comprehensive assessment that you can trust in. And if you want to use alternative things like nutrition, fish oil, other types of things, good. Just like with anything else. It's not just about the medical care, it's about your overall wellness. So I am very in favor of that. What I'm not in favor of is stupidity. So not screening people, not giving people the choice, making the decision for them by saying, we're never going to ask you if you have an illness, is wrong. You need to empower people with information. And you know how often these screens work, like the PHQ-9 for depression? It works 80% of the time in terms of finding people with depression. Do you know what happens with the 20% it doesn't work on? They lie. Why do they lie? Because they're doctors, they're police officers, they're pilots. There are people whose jobs will be threatened if they are diagnosed with a mental illness. And first of all, it is so stupid that, I use this word stupid, I apologize, but it is probably a technical term that applies quite well. To have these rules focused just on mental illness, what we should be looking at is functional impairment. If you can't functionally do your job, then you should not be able to do your job. And we do need to be careful with pilots. I mean, pilots, it's a really hard job. And we need to be careful with people in the military. But there's ways we can do that to help people recover and help people get better, as opposed to just say, as a pilot, if you come up as depressed as a pilot, your license is suspended. So is that the right thing to do forever? I don't think so. I think it's probably the right thing to do, obviously, if you're impaired and you can't fly, but to have a way to get back so you can fly. These are treatable illnesses. And if we treat them like, okay, this is a mark, like a black mark where you're off the list now, that's a real problem. And then I'd say the last thing is that we need to really empower parents, because these are pediatric illnesses. We can't just treat kids. We can't just give people pills. We got to help parents figure out how to be an effective parent of a child who has more emotional needs. And one thing I'm so excited about is we have this new partnership thanks to an organization called the Goodness Web, which is invested in a big project here with Children's Health and us to take this thing called collaborative problem solving. It's a way to help parents think differently about discipline. It kind of moves away from the idea that we have to motivate kids to be good. There's no scientific basis of that. All kids want to do a good job, even the ones that don't seem like they are. They just don't know how. And so it's really, it's helping parents have the tools to teach their kid how to do a better job, how to be able to, tolerate frustration, put off delay gratification, all the things you need to learn how to do that a lot of us learned at church, actually, growing up, right? And kids still do, but a lot of kids aren't getting those lessons. And also some kids need a little bit more intensive things. So I think those are the things that would make it a little bit better. Does that get to what you were thinking about, or were there other things you were thinking about?
Also, refusing therapy as well.
Refusing therapy? Yeah. I mean, what's the circumstance where someone might do that? What are you thinking about?
I just don't think it's going to help.
Yeah, okay. I think that you do have a mindset, but most parents today, it's not the same as when I was parenting my kids. Most kids and parents say if you do surveys, they're fine. Like, most parents, we actually have gone into, when there was a lot of pushback again, some of the things going on in school, people were worried about, well, should we offer therapy in schools? We did some focus groups in collaboration with another group of primary voters in North Carolina, of conservative Republican primary voters, as well as Democratic primary voters. And what we found was that if you used words like, social emotional learning, buzzwords, jargon, they were like, I don't know what that is and I don't want that for my kid. But if you said, hey, if your kid has depression, or you're worried about your kid in terms of their emotional wellness, would you want the school to help you find a therapist? Almost all of them said yes. So that's really changed in terms of awareness of it. I think it's much more, is it the right therapy? Is it the right thing? We don't see that. Now you do in some groups. There are some subgroups, but most parents today are pretty open to it. So that's a fortunate thing.
Dr. Keller,
Yes.
when you were talking about the schools and getting to 98%, I mean, with the funding and so forth, I noticed it was ISDs. You referred to private, so is this referencing also private schools in Texas, and then also what about the university level?
Yeah, so the initiative right now is primarily focused on ISDs. I think that there are ways for other local educational agencies, including private schools, to get involved. And so, and I would love to have a group of private schools that wanted to do that, to try to figure out how to get involved in that and how to get the right supports, and also to make sure that there was the right supports that fit the culture and values and perspectives of that particular school. So we need to figure that part out. This program didn't start up until 2019, didn't get funded until 2019. It launched in May 2020. It was ramped up to about 40% of students by the fall of 2020, which is why it broke my heart that it wasn't in Uvalde, because it could have helped there. We're going to have it in all of the public schools by the end of next school year, but I think if we were to have a focused effort, which we can do. I mean, we have projects working on this. You don't need to give us money to go do that. You can always give us money if you want. We are a nonprofit. We're not the Meadows Foundation. We're the Meadows Institute, so we do need money. But for this kind of thing, we have some funded projects. We would love to talk with y'all and whoever the right folks are about that, because I think there's some ways to access the existing program as well as to add some additional enhancements. These are all very friendly questions. I wanted harder questions. They're hard questions to think through, but no one all right, give me a hard one.
The troubled kid, high school, refuses treatment, uncooperative parents.
Yeah.
How do you interface with social, police, government? What do you do?
So MST, that program right there, MultiSystemic Therapy, is designed for that family. It is designed for the Uvalde shooter's family. An overwhelmed parent, inadequate resources, out of control young person, not following directions, that is who it was designed to serve. So what they do is during the first month of engagement, this team, they only have 4 kids that they're helping at one time, the team. It's very intensive. They will hang out with, they will go talk, they will go to their house or wherever they want. If they don't want to go to their house, they'll go meet them somewhere to talk to the family, but talk to the whole family. Talk to grandma, talk to grandpa, talk to aunts, uncles, talk to the teachers, talk to the principal, talk to the police who have encounters with them, talk to everybody and say, who are the adults who can step up with additional resources and actually be a presence in this person's life. The Uvalde shooter had a mom who was substance using, who was outside the thing. They had a grandpa, he had a grandma, who were all struggling individually to do what they could do, and I think do their best. I mean, I don't want to criticize them, but what they were able to do was inadequate. It's exactly the kind of family that this works with, and it works 70% of the time. They will help that family, and the 30% of cases where they don't is almost entirely driven by the fact that some families have no adult who is willing to do that. That's just the unfortunate fact. We have about 30% of those 10,000 kids who there is not any adult in their life who is willing to take responsibility to be there after school, to be there to do the homework, to be there to get them to school. And that's the hardest part. And that's the part that we can't fix with a health system. We have to really fix that with society, and we have to fix that with, faith communities, others who can help partner. So that's the hard part. That's the part we don't know what to do yet. Does that make sense?
The issue about going in and removing weapons.
So red flag laws? It is something that we've done a white paper on, and the evidence on them is not great. because they're so early and there's not been a lot of studies. By the way, the evidence on masks wasn't great, but I still used them. But we believe that the law in Florida is pretty effective. And there's going to take more time to see if it works. The thing I like about the law in Florida is it has constitutional protections, because you need, especially in a state like Texas, you're going to need to have a way to get access to, you can't give up hunting and having weapons forever. But if you are in a place where you're dangerous, to have those taken away is just a reasonable thing, and it's the kind of thing that we don't have the laws to do here in Texas. Dorina, can we do one more? Okay, cool. All right. Because I'll talk all day, and you got to stop me. So stop me before we go all day. Yes, ma'am.
Okay, here's the tough question.
Yay. That was a good one.
I'm actually from an area just east of Uvalde, poor ranching community. You know, actually we considered Uvalde to be the big city.
Yeah.
A lot of people look like me.
Yeah.
Not much in terms of money, not much in terms of access to medical care. And I know what you mentioned about, you know, and granted, I do not condone what he did. That young man, but you also have to think about the grandparents who may have tried to do whatever they could.
They did.
They didn't have access to medical care. You try to go to a therapist, they don't accept insurance, even if they had insurance. So, you know, and this program sounds really good, but how do they get access to it if they don't have the funds?
Yeah.
Or even have the ability to even know that programs exist?
Yep. So that was a fantastic overview of all the barriers. Those are the main barriers, right? Including, I would add, and I think you alluded to this, but just to be explicit, having someone from my culture who speaks my language, who speaks the language I primarily speak in, if that's Spanish or other languages. There's so many barriers. So the TChat program is free. There's no cost. It's paid, we pay for that. Taxpayers of Texas pay for that. It is insurance blind. And it is designed for the school, when they notice there's an easy button. They don't have to do anything other than refer. Now, getting grandma to agree may have been hard, right? Because maybe grandma didn't want to do that. Maybe grandma didn't have the resources to do that. Maybe grandma didn't understand. Well, it's gone. Maybe the person who talked to grandma didn't speak grandma's language. I don't remember if she was primarily Spanish-speaking person or not. That's where some of these outreach teams become really important, where community health workers become important. You've got to put those supports in place. So we had the honor of doing the regional assessment for Uvalde, for the community of Uvalde, in partnership with the school district, the consolidated school district, in partnership with the hospital that's there, with the mental health folks that are there. We did that evaluation. We released it in December of last year. The legislature has fully funded that $50 million improvement for the Uvalde region. And I think, and the thing that I was so happy about with that report was the mayor of Uvalde and the county judge of Uvalde both said our community supports these recommendations. We believe these fit the values of our community, and we want to do these things. And we looked really hard at these workforce issues, because you can't bring people somewhere where people don't live, but you can through telehealth. And so I'm happy to send that plan for folks to look at, but we think that it's not a panacea, but there are ways to build and have things be incrementally better, but it's going to be addressing the barriers that you said. You have to take those seriously, and you have to do it in partnership with families, and you have to do it in partnership with faith community, and you have to do it in partnership with everybody in that community. And that plan is something that we had all those people endorse. So that was a wonderful description of what needs to change. It's daunting when you think of all those things, but the reality is those are all changeable things. Those are all things we know how to do. We just have to have the will and the willingness to spend resources to do it. And that's what I'm hopeful about, is it's not rocket science. It's about just deciding to do things differently. And I think we're seeing that. So that's my partial answer. It's going to take time. But I think 10 years from now, it's going to be different. It's going to be a lot more like it is for these other diseases. So does that make sense? Thanks for asking that. You guys, those were great questions. I mean, they were super helpful. Thank you so much for letting me be here and for this discussion.